warm welcome, everybody. I would like to thank the organizers of this meeting for giving me the opportunity to talk to you about the evolution of CLL treatment to targeted therapies. And a big thank you also to Abbvie for sponsoring this symposium. These are my disclosures. In the last 20 years or so, we have seen a huge evolution of CLL treatments and goals of therapy, all the way from initially just alleviating symptoms with single-agent chemotherapy to improving survival, in particular with the addition of rituximab to the chemoimmunotherapy backbone in 2010 through the German CLL8 study. And then all the way to the introduction of various different targeted agents that have not only further improved the outcomes of our patients with CLL, but also reduced toxicity from chemoimmunotherapy quite significantly. So I would like to illustrate these advances in 3 different case studies, starting initially with a patient who required therapy in frontline, a 75-year-old gentleman who was diagnosed with chronic lymphocytic leukemia 10 years earlier. He presented to the ear, nose, and throat physicians with a history of recurrent tonsillitis and fever that responded to antibiotics, but has had experienced increasingly difficulties in swallowing and altered voice due to enlarged tonsils. So he was referred to hematology by the ENT surgeons. While I was taking the past medical history, it turns out that he had actually suffered from recurrent chest infections for quite some time, but was followed up only by his general practitioner and not by a hematology specialist. He had pulmonary embolism 15 years ago, and then a second pulmonary embolism 7 years ago, and was on lifelong rivaroxaban. He also had atrial fibrillation. He was on a beta blocker, but no hypertension. And he checked his blood pressures regularly at home. He had been seen for skin cancers, both squamous carcinoma and also basal cell carcinomas. And he'd undergone radical prostatectomy for prostate cancer 16 years ago. So he had quite a few comorbidities, but was actually, when I saw him, very well in himself. He had huge tonsils that were almost touching in the midline, and some cervical lymphadenopathy. There was not much else on CT scan in terms of lymphadenopathy, but he had left lower lobe bronchiectasis with volume loss that was put down to a secondary immunodeficiency. And the full blood count is shown, as you can see, with a mild lymphocytosis and preserved hemoglobin and platelet count. He did not have, interestingly, any hypoglobulinemia on serum electrophoresis, despite the clinical presentation of recurrent infections. And he was hypermutated at the immunoglobulin locus, TP53 wild type, and did not have any 11q abnormalities. His EGFR was 69 milliliters per minute. So here we are, an elderly gentleman, quite well and fit in himself, although he had multiple comorbidities with what looks like standard risk or good risk CLL requiring treatment for the first time. So I would like you to invite you to think about which therapy you would consider in 2021. And although we can't do the polling live, these are my polling questions. Would it be bendamustine and rituximab or even milder chemotherapy, venetoclax and rituximab, idelalisib, rituximab, acalabrutinib, or ibrutinib? And clearly the answer to this question depends on whether or not those regimens are approved in your country. And then the second polling question is about the factors that are influencing treatment choice in the first line setting. And I've listed some of them here. They're basically divided into patient-specific factors like the age, comorbidities, fitness, the disease-specific factors. In particular, the genetic factors of the immunoglobulin status and TP53 aberrations, and then more practical considerations, the cost or the access availability of the regimen, how easy it is to administer, the length of treatment, in particular in the context of the COVID pandemic. So we discussed the different treatment options together with the patient and with his wife, in particular focusing on continuous versus fixed duration therapy, because it's important for me to also understand what the patient preferences are. And some patients will clearly not want to be on continuous therapy, whereas other people don't mind. And then we were also discussing the side effect profiles of the different agents. So Venetoclax based therapies where tumor lysis might be experienced at the beginning, and patients might require close monitoring at the beginning of therapy, versus the BTK inhibitors that are primarily characterized through bleeding tendency and then also cardiac side effects. In the end, because of his cardiac history and the fact that he's been on rivaroxaban and had atrial fibrillation, we decided that we would opt against a BTK inhibitor, which would have been ibrutinib at the time, but basically proceeded with Venetoclax and Obinutuzumab therapy. As you know, that's a fixed duration therapy that's given over 12 months in the frontline setting. The side effects are primarily infusion-related side effects, particularly in patients with high white cell count. So this did not really apply to him because his lymphocyte count was only 29. The need for weekly attendance during the COVID-19 pandemic for the first 5 weeks, and then monthly for 5 more months because of Obinutuzumab and Venetoclax. So that is clearly also one of the practical issues that one has to consider. And the fact that the regimen contains an anti-CD20 antibody means that the patients might be at an increased risk of getting severe COVID infection. And then the tumor lysis risk, which again in his case was not so much of a problem, because apart from the enlarged tonsils, he didn't have much and he didn't have bulky lymphadenopathy on CT scan. So basically, he had the therapy as an outpatient. It was very straightforward. He finished Venetoclax Obinutuzumab. This was during the COVID-19 pandemic, achieved a complete remission without any side effects at all, and is now off the therapy and well at home. So these are the Esmo guidelines for the treatment of first-line CLL in 2021. And as you can see, this patient here would fit into the middle of an IGVH mutated patient, no TP53 mutation, but maybe because of his comorbidities, considered as a relatively unfit patient. And the frontline treatment here is advised to be Venetoclax and Obinutuzumab. Just to review now the evidence for this decision, there have been many clinical studies in recent years, all looking at the role of targeted therapy, primarily ibrutinib-based therapies versus chemoimmunotherapy, and showing superiority of ibrutinib. And then more recently, studies looking at both in fit patient and unfit patients, looking at in the unfit setting, comparing ibrutinib and also venetoclax-based regimen and acalabrutinib-based regimen against chlorambucil and obinutuzumab. So with respect to the very first big study that we can all remember being shown and presented at ASH a long time ago now in relapsed patients using ibrutinib versus ofatumumab, showed a very significant progression-free survival advantage of patients treated with ibrutinib. And this was a very high-risk cohort of people. So it was a very impressive results with a median follow-up of 65 months. Subsequently, then the ibrutinib was also tried in the frontline setting, and the PFS curves are summarized here, both for fit patients. Ibrutinib rituximab was compared against FCR, and then for the less fitter patients against bendamustine and rituximab. Interestingly, this was the Alliance study that also showed that there was absolutely no difference with respect to PFS by the addition of rituximab to ibrutinib. And then the Illuminate study that compared the combination of ibrutinib and obinutuzumab against obinutuzumab and chlorambucil in the less fitter patients. All these studies showed very significant progression-free survival benefit for the ibrutinib. Now, interestingly, in the younger patients and the fit patients, the ECOG study also showed what appears to be an overall survival benefit, but the numbers in each arm, as you can see here, it's a 2-to-1 randomization, but the numbers remain quite low. And we are all eagerly awaiting the UK FLAIR study results that, again, will have a comparison between FCR and ibrutinib and rituximab. So what are the side effects of ibrutinib? I've already mentioned in our patient, he had a history of hypertension. He had a history of atrial fibrillation. And you can see these are the major adverse events of clinical interest over time for ibrutinib. There are others that are of concern, the bleeding, major bleeding, in particular in patients who are also on other anticoagulants, and then the risk of infections in about 10% of patients. As you can see, in particular, the risk of pneumonia does not really decrease over time, but remains an ongoing risk. And when patients are on ibrutinib for a long time, especially when they have secondary immune deficiency, that might be of concern. More recently, we have seen data on acalabrutinib in the Elevate treatment-naive study that compared single-agent acalabrutinib to acalabrutinib and obinutuzumab, and then chlorambucil and obinutuzumab combinations. And this study showed a very significant advantage of the acalabrutinib-containing arms against the chemotherapy. There was no overall survival benefit in this study. But however, with longer follow-up, it appears that the addition of the obinutuzumab might actually further increase the progression-free survival. So this is an interesting observation, and hopefully we'll see more even longer-term follow-up of this study coming through. The importance, though, of this study was that it showed that acalabrutinib had quite a favorable safety profile in that the main issue with acalabrutinib is headaches that are usually well controlled with either painkillers or caffeine-containing drinks. And then the fewer adverse events when it comes to cardiac events compared to the ibrutinib. coming on to the Venetoclax Obinutuzumab data now. As I said already, it's a 12-month fixed duration regimen. This was first evaluated in the Cll12 study against cloambucil and obinutuzumab in patients with significant comorbidities. So this is really the data that let me prescribe Venetoclax obinutuzumab in my patient. You can see that the 4-year estimated progression-free survival of 74% is very impressive, considering that this is a fixed duration regimen that stops after 12 months. There was no overall survival difference reported in Cll12 against the chemoimmunotherapy regimen, but we're not really expecting this because, of course, these patients could, the chemoimmunotherapy treated patients were switched to targeted agents of study at relapse. So Venetoclax obinutuzumab induces very deep responses, including undetectable MRD in about 75% of patients in the peripheral blood and just under 60% of patients in the bone marrow. And this is very different to ibrutinib or the other BTK inhibitors. Patients with undetectable MRD after Venetoclax obinutuzumab have an excellent progression-free survival that is well over 85% at a median follow-up of almost 40 months. And Venetoclax obinutuzumab also allows a prolonged treatment-free period. So it gives you progression-free survival, but a 4-year treatment-free survival of 81%. Meaning that not all patients need to start treatment immediately after progression. It is, however, fair, though, to say that with longer follow-up of the fixed duration regimen, and this applies to the relapse setting as well, that the poorer risk patients from a genetic perspective, and here I've shown the immunoglobulin status, that the poorer risk patients, i.e. the ones with unmutated immunoglobulin status, also fare slightly worse compared to the hypermutated patients with a fixed duration regimen. So you can see that with longer follow-up here, the dotted line, which are the unmutated patients, they are kind of dropping off. This is not so much the case with ibrutinib in the Resonate-2 study, nor is it the case with acalabrutinib in the various combinations of acalabrutinib in Elevate treatment naive, or in the Alliance study, again with ibrutinib. It is reassuring, though, to say that Venetoclax obinutuzumab is very well tolerated. The longer follow-up of the Cll12 study did not show any new safety signals or increases in known toxicities. We know that Venetoclax obinutuzumab can lead to tumor lysis syndrome, in particular in patients with bulky disease or patients with impaired renal function. But once you are over this initial dose escalation, it's exceedingly well tolerated. There are some patients who will develop neutropenia, but that does not really translate into an increase in infection, at least not in this combination. It might be different in combinations with BTKI or even in triplet combinations, because we see an increase in infection there in older people in particular. But in this combination, just with obinutuzumab, that seems to be fine. There is, however, of course, a risk of infusion-related reactions, as you would expect with an obinutuzumab-containing regimen. There was initially a worry about second malignancies in the short follow-up of the Cll12 study. That has not been been confirmed in the longer study, in the longer follow-up. So there have been very few second malignancies in the study in either of the arms. So just to remind you, in terms of the practical considerations when prescribing Venetoclax and Obinutuzumab, it is very important and essential to bear in mind that the dose escalation has to happen over a 5 weeks period, starting with 20 milligrams and then dose escalating every week. During this time, patients need to have tumorolysis bloods taken both before and after dose escalation, both after 8 hours, 12 hours, and then 24 hours later. And high-risk patients need admission to hospital. The second case is a 42-year-old father of 2 primary school children. So he's very much on the younger end of the spectrum of CLL patients. He was diagnosed with CLL during a routine medical exam for his employer with just a lymphocyte count, very good kidney function, and no palpable lymphadenopathy. So he was stage A CLL when I saw him. And I basically said to him that he's young and it'd be quite unlikely that he would run into trouble anytime soon. Of course, I shouldn't have said that without having done any prognostic markers, because just a year later he presented still stable and well, but he had small nodes on clinical examination, and so I then labeled him as early stage B disease. And the question really at the time, that he was asking and his wife was asking, who is a nurse, do I need treatment at this point in time? And that's something that you can also reflect on, and we can discuss during the live session later. So would you have treated this patient, progressing, quite well in himself, but progressing from stage A to early stage B CLL at this point? So early treatment for patients with stage A CLL, definitely no benefit. Just summarize the historical studies now here that looked at chlorambucil with or without prednisolone and no treatment in patients with stage A CLL. And there was no overall survival benefit for early versus no treatment. Same outcome really for single agent fludarabine back in 2017. There was a risk stratification happening in this trial, but the risk factors were not very good risk factors, and they didn't differentiate that well high risk from low risk patients, but there was also therefore no overall survival benefit. And then most recently, the Cll12 study from the German CLL study group that has a very similar study design to the Cll1 study, looking at watch and wait versus ibrutinib versus placebo in patients with high risk disease or intermediate risk disease. Again, the high risk criteria are the diffuse bone marrow infiltration pattern, a lymphocyte doubling time of less than 12 months, a serum thymidine kinase that is raised, and a beta-2 microglobulin of over 3.5 milligrams per liter. So very general and not very predictive high-risk features, one would say. So I decided not to treat the patient, despite the fact that he had a small increase in his lymph nodes. In March 2020, then he presented with tiredness. And you can see that he's dropped his hemoglobin, he'd also dropped his platelet count, and he did actually then have a lymphocyte doubling time of less than 6 months. So now he was, strictly speaking, stage C disease in need for treatment. And it's at that point that I decided to do some genetic markers. So he was unmutated, as one would expect in a rapidly progressing patients like this. And he had TP53 results that actually were not completely straightforward. There was a variant in the DNA binding domain, but the lab had said that it was of uncertain significance. It had only been described a couple of times in CLL before. And there was no deletion of 17p by FISH. The CT scan showed widespread small volume lymphadenopathy, really not very large, a largest node of 24 times 16 millimeters. So again, we discussed the different treatment options, fixed duration versus continuous, and the patient and the wife expressed a very clear preference for fixed duration and no chemotherapy because the patient was young, very well informed, had young children, so he just wanted to have, this problem of CLL be treated and go away again as quickly as possible. Just as a reminder, for the TP53 analysis, as you know, we inherit a maternal and a paternal allele of all chromosomes, including the chromosome 17. There's a P arm and a Q arm. The abnormal variants in CLL are depicted here. The most common type of abnormality is that there's a deletion, so a missing bit of chromosome 17p with the mutation on the other allele. That makes up for about 60% of all patients with 17p or TP53 abnormalities. There's then a very small group of people that have got a deletion but without a mutation on the other arm. I probably think it's less than 6%, 10%, but these people have probably a relatively normal outlook. And then there's this group of people with either monoallelic or biallelic mutations in TP53, and they make between 30 and 40% of all cases. And so when you only do FISH analysis, you will only picking up those 60% with a deletion, and you're not going to pick up the 30-40% of people with mutations. That's really why it's so important that we do both mutation analysis and FISH on, before each round of therapy. So there's quite limited PFS data available for some frontline targeted agents by TP53 status. But as you can see in the Cll12 study, where we've now got a longer follow-up of over 50 months, you can see in the dotted line that the patients with TP53 dysfunction are clearly not doing as well as the patients who are wild type, the TP53 locus. So whether it's the Venetoclax or whether it is the fact that it's fixed duration therapy, it shows that maybe it's a combination of both, that those patients might not benefit that much, or might benefit, but will benefit well, but benefit less than patients who are wild type. The same cannot be said with the with ibrutinib and the continuous therapy. So you see here that patients with TP53 abnormalities are doing quite well. However, the numbers are small of the people with the TP53 abnormalities. And of course, we're not really comparing like with like, because really, with Venetoclax or Obinutuzumab, there's an opportunity to retreat with Venetoclax or Obinutuzumab, or with Venetoclax rituximab rather, or with Venetoclax monotherapy. So really what we should be comparing is the PFS2 and not the PFS1 as it's currently done when we're comparing like this across all the clinical studies. So with this patient, we actually did start him on Venetoclax or Obinutuzumab because he had a clear preference for fixed duration, and because the TP53 variant was reported as being of uncertain clinical relevance. However, after he then had his 12 months of therapy, we assessed the MRD with flow cytometry, and his MRD levels were not brilliant, basically. So at 0.1 times 10 to 9 per liter. So we were, I wasn't that pleased. I should say also that he had had not been able to tolerate Obinutuzumab therapy, and because of a very severe infusion-related reaction, and then subsequently really didn't want to have that anymore. So to some extent, he was really undertreated, which was also another reason why I proceeded with MRD examination. So he was MRD positive at 10 to the -1. And we made the decision to continue with Venetoclax monotherapy for another 6 months because he had private insurance and he could therefore decide outside of the NHS rules and regulations how much Venetoclax would be good. So we then decided that quite arbitrarily that if the MRD levels fall, we would continue with Venetoclax after 6 months. If they were stable or rise, we would obviously discontinue and switch to BTKI when clinically indicated. Now, in August of this year, his MRD level had dropped by another log. So he's still detectable, but much better than it was in March. And so we therefore decided that we would continue the therapy for 24 months and then probably stop at that point. And it would be interesting to in the live discussion to pick up on this and get other people's view on this management that is really a real world management and not so much a management that is based on clinical evidence and clinical trial evidence at this point in time. So the third case is now going into questions of treating patients with relapsed refractory CLL and also the sequencing question that we are all facing in the new era of targeted therapies. So this is a 74-year-old retired nurse who was married to a retired GP. And she was diagnosed with Binney stage C CLL and compensated autoimmune hemolytic anemia in 2012. She her IgHV status failed, and we never got any results. The SIR score was over 6 because of well-controlled comorbidities, and her creatinine clearance was 60 milliliters per minute. She had a compensated anemia, as I said before, and a normalish platelet count. She was actually okay for 3 years, but then she presented with a large soft tissue mass over her parietal bones that was extending into the skull intracranially, but remained extradural. A biopsy confirmed that it was just CLL and not anything nasty, no high-grade transformation, and she received local radiotherapy, to which she responded locally really well. But unfortunately, about a year later, she then became symptomatic with her autoimmune hemolytic anemia and dropped her hemoglobin, and had also had some systemic disease progression. So initially, we treated her with steroids to get the hemolysis under control, and then after we tailed the steroids, she was okay for a little while, but then basically had increasing cytopenia, pancytopenia. So at that point, her cytogenetics were normal by FISH. And we started her on first-line treatment with ibrutinib. This was at the time also privately because ibrutinib has never been approved in the frontline setting in the UK, apart from for patients with TP53 abnormalities. So unfortunately, a few days after starting ibrutinib, she got admitted to intensive care with a community-acquired pneumonia. And at the time, because she had pneumonitis, post-pneumonitis lung changes, and also bronchiectasis, the chest physicians thought that she might have got a drug-induced pneumonitis. So we decided that she had to go onto steroids and infection prophylaxis, and the ibrutinib was permanently stopped, although she had actually a good response. So the patient herself, after all this, was not really keen on continuing ibrutinib. The first relapse then was in about a year later, when she had nodal disease progression and another recurrence of her hemolysis. At that point in time, she remained a wild type for TP53 abnormality. And so the question here then is really, what treatment would you select for this patient who is intolerant to ibrutinib? It says on the slide, relapsed patient. Now in the UK setting, we would probably still consider her as a first-line patient because she only had very little ibrutinib and the radiotherapy was localized treatment. So, but really the question is, what therapy would you initiate? Chlorambucil, Obinutuzumab, ibrutinib, Venetoclax, and rituximab. That was not available at the time in the UK. Idelalisib and rituximab. That was for relapsed patient, but not in the front line, acalabrutinib, or anything else. So again, we can discuss this in the live session. And then the other really important point, I think, is when to routinely test for the TP53 abnormalities. And the guidelines say, and I would concur with this, is that it's really important to test before each line of therapy. And that is primarily because even although it does not change the immediate management, because in a relapsed patient, it will always be a targeted agent that we will choose for treatment. It might actually become relevant in younger patients, of course, because of selection to more definite treatment with allogeneic bone marrow transplant or CAR T cells. But then also in older patients, really for inclusion into clinical trials that might select patients on the basis of the TP53 status. So for me, this remains an important question, and it also helps, still helps to unpick a little bit better and predict a little bit better what the overall prognosis of the patient will be. So we decided to start Obinutuzumab and chlorambucil, and she was given a lot of anti-infection prophylaxis, including antibiotics against Pseudomonas and Septrin. And she just about achieved a partial response with normalization of her lymphocyte count and an over 50% reduction in nodal size. However, not even a year later, she relapsed again with bulky nodal disease and the recurrence of hemolysis. And at that point, she actually had the TP53 mutation in the DNA binding domain of TP53. So the question is, what treatment would we now give to a patient who is intolerant to ibrutinib, has progressed on just after mild chemoimmunotherapy, and has now developed also a TP53 aberration. So would we go for more chemotherapy with bendamustine rituximab, ibrutinib, Venetoclax rituximab, idelalisib rituximab, acalabrutinib, or anything else? What we did was, we were lucky because now Venetoclax was available, and so we started her on Venetoclax and rituximab with, again, PJP prophylaxis. Why did we do this? Well, because the Murano study had been published and had shown very excellent outcomes of patients with relapse refractory CLL after 1 to 3 lines of therapy, which she fitted into this group of patients very nicely. It had also shown a much better progression-free survival compared to bendamustine and rituximab, which would have been another chemoimmunotherapy in the relapse refractory setting to consider. So in particular, patients similar to the Cll12 study, patients with undetectable MRD, of which there are many, and the majority have undetectable MRD, even in the relapse setting, with venetoclax and rituximab. So those patients show a very good progression-free survival. And similarly to patients in frontline, in the Cll12 study, you can see that the median progression-free survival of patients on venetoclax and rituximab in the relapse setting was 53 months. So they got in the 5-year estimated survival of 38%, which, considering that you stop the regimen after 2 years, is very good and shows that the duration of response is durable. There was also a survival benefit compared to bendamustine and rituximab, clearly demonstrating that chemoimmunotherapy is not something that we would use in patients with relapsed refractory disease. And again, as in Cll14, the patients who responded well to venetoclax and rituximab also showed a longer time to next treatment. Of about, almost 58 months in total. The safety profile of patients with relapsed refractory CLL on venetoclax and rituximab is not dissimilar from the patients in the frontline setting. Again, there were not the initial signal of the skin of the cancers, second cancers, was not confirmed, and the rate of other side effects, in particular grade 3-4 side effects, was comparable or favorable compared to bendamustine and rituximab. There was a higher incidence of neutropenia, as we've said already, but that again did not translate into a higher risk of infections. So what happened to the patient? So she tolerated venetoclax and rituximab well. However, we were never able to fully dose escalate her because she developed very significant symptoms of fatigue when she went on to 400 milligrams, and it was bearable and manageable at 200 milligrams daily. And we did twice, we tried to escalate and it failed. So we, in the end, kept her on 200 milligrams daily. And when it came up to the 2 years, we then essentially decided that she would continue venetoclax monotherapy, partly because she was so well on it. She had the fatigue, but she was so lucky that she had good disease control and that the hemolysis was under control, that she felt very reluctant to stop the drug. And clearly, because of the TP53 mutation, it was felt that that maybe a prolonged course would help in keeping her disease under control for longer. So earlier this year, she had a fall, a very unfortunate fall, and essentially had an abdominal CT scan as part of the investigations that showed that she had an enlarged lymph nodes in the para-aortic region, but she remained clinically well, and there was clinically no peripheral lymphadenopathy, and her blood count remained well apart from the compensated hemolysis. So the question is really here how we would manage this at this point. Would we change therapy, or would we simply continue with the venetoclax monotherapy? So I decided that we'd just continue because it was just one CT scan and just a couple of nodes. However, 8 months later, I thought I'd better repeat the CT scan because I couldn't completely ignore this. And so at that point, her lymphadenopathy had increased to 6.7 centimeters. She was also feeling a bit more tired again. So we basically thought that she needed a switch to a different regimen. And the question is now, what would we do in a patient who is intolerant to ibrutinib, progressed on chemotherapy, was then on venetoclax for the best part of 4 years. So what are the options now? So again, we were quite lucky in that acalabrutinib got approval in the UK last year during the COVID pandemic. And we therefore decided that she would start acalabrutinib. And the rationale for this is basically, number one, that the Elevate-RR study that compared acalabrutinib against ibrutinib, a head-to-head comparison, showed that acalabrutinib is non-inferior compared to ibrutinib, both with respect to progression-free survival and with overall survival. So it's always good to have head-to-head comparison because the data is very clear cut then. We know from the phase 2 trial that acalabrutinib is effective in ibrutinib intolerant patients, and that there's very often no reoccurrence of the side effects. And so I was quite hopeful that if ever this was a pneumonitis, that this would not recur when she started acalabrutinib. And acalabrutinib has a tolerable safety profile in relapse refractory CLL. We know that from the Ascend study. And we also know from the direct head-to-head comparison that the safety profile of acalabrutinib is favorable compared to ibrutinib, in particular when it comes to cardiac side effects. So this is demonstrated here in more detail, where you see that the rate of hypertension, in particular in atrial fibrillation, is reduced in acalabrutinib compared to ibrutinib. Clearly indicating that she might have a better time on acalabrutinib than she would have had on ibrutinib. So how about the sequencing then, and the real world data that we have to guide us through the treatment choices for patients with relapsed refractory CLL? The first question is, do we start with venetoclax or do we start with ibrutinib in relapse? And there's really no clinical trial data for this, and probably will never be clinical trial data for this question. But we know from the real world data from both US and the UK that both venetoclax and ibrutinib are very effective agents when it comes to with the relapse refractory setting, possibly venetoclax providing a bit longer progression-free survival compared to ibrutinib. And I think that is potentially because of the higher discontinuation rate of ibrutinib. BTKI therapy after venetoclax is effective in BTKI naive patients. So whether we start with BTKI and then go on to venetoclax or do it the other way around, both strategies are successful. The post-venetoclax PFS in a BTKI naive patient, which is sort of what she was. She only had a few days of ibrutinib. It basically shows that the PFS is about 3 years, which is actually she did a bit better than that. So, but maybe because she hardly had any other treatment before that. So it clearly also that, as you can see here, that the BTKI naive patients will do better with respect to overall response rates compared to patients who've been exposed to BTKI. The BTKI therapy is also effective in patients with venetoclax resistant CLL. So this is also her case. And you can see that there are overall response rates of 91% in this setting with, again, very reasonable progression and overall survival. And the BTK exposed patients, the response to BTK depends on the reason. And so that is essentially in her case, because she was intolerant to ibrutinib, you can see that her median PFS on Venetoclax should be really good. On the other hand, the post-Venetoclax PFS for PI3 kinase inhibitors in PI3 kinase naive patients is not that impressive, with a median PFS of 5 months. So the other reason why I didn't consider PI3 kinase inhibitor in my patient is, of course, because we all know that PI3 kinase inhibitors show an increased risk of not just colitis, but also pneumonitis, and which clearly was not ideal in her case. So the Esmo guidelines for the treatment of relapsed refractory CLL are summarized here then, and you can see that really depending on the duration of remission, retreatment might be indicated. This applies in particular to the fixed duration regimen, of course. But that other than that, ibrutinib, acalabrutinib, or venetoclax and rituximab are all very good options for patients in the relapsed refractory setting. This is also echoed by the BSH guidelines that are currently under review and will hopefully be published very soon. But you can see that our choice of second-line agents here in the middle includes venetoclax, rituximab, or acalabrutinib. In the last couple of slides, I just want to provide an outlook of the emerging therapies that will be available. We've already seen that the treatment of CLL has become quite complex, and we have many choices, which must be a good thing for our patients. However, it's also clear that CLL remains an incurable disease. One way to try and address this issue is by testing more and different therapeutic avenues. And one way of doing this is through the next generation BTK inhibitors. And we have interesting drugs at the horizon. The irreversible covalent binding zanubrutinib is one example, and then there's also reversible non-covalently binding drugs available now in the form of pirtobrutinib and ARQ-531, and hopefully we will see further clinical studies, both investigator-led and also industry-sponsored studies of these agents very soon. The second approach is to essentially realize that many of our patients will be functionally cured through the sequencing strategies that we are currently developing, and they will ultimately die of non-CLL related causes. And thirdly, there's a lot of excitement around combining existing targeted therapies to see whether they would lead to cure in a certain percentage of patients. Of course, that brings with it an increased risk of toxicity through combination therapy. And also the question is, is this something that we want to do, treat our patients with everything we have available? Because what happens if they then progress? So many open questions that remain that have to be addressed within clinical studies. And I will stop here, and I hope you enjoyed listening, and I'll be very excited to participate in the live Q&A session. Thank you.